Good evening, everyone. I hope you can hear me. And thank you to Joel and others for having devised and created what promises to be a really fascinating evening discussing the science of vaccinations. I'm Harvey Bolofsky, the Senior Rabbi at the Golders Green Synagogue. Many of you know me, but for those who are looking in from other communities or other places, a very warm welcome. And a particularly warm welcome to our distinguished panelists, Professor Daniel Hochhauser, Professor Benny Chain, Professor Madi Nursadehgi. Thank you so much for your time and for your willingness to share our expertise with our community and beyond. Now, you're here to listen to our experts, not me. But Joel kindly asked me to frame the evening with a few words. I'm going to start with a very brief story that Vicky saw reported on Gabriel Cantor Weber's Twitter feed recently about smallpox vaccinations in the 1890s, which were then at the time required by law. There was a chap called Henry Levy, and he refused on religious grounds to have his son vaccinated and was subsequently imprisoned. The prosecutor, another Jew called Harris, felt some remorse, and he wrote to the chief rabbi, then Rabbi Herman Adler, who replied that vaccination is in perfect consonance with the letter and spirit of Judaism. It's a great story, one which I'll finish in a few moments, but it's an opportune segue into a very brief halachic introduction to the topic. There is a long-established halachic principle that one follows the majority view among doctors when evaluating whether to have a certain treatment. In fact, the halacha has a sophisticated approach to risk-taking, and it strongly rejects the idea that one should avoid a small risk, for example, one associated with vaccinations, given the potentially huge consequences of not being vaccinated for oneself and for other members of society. And in fact, in many circumstances, halachic sources regard taking such small risk as mandatory. Here are a few contemporary or recent examples from across the religious spectrum within the Jewish world. Rabbi Osher Weiss, today regarded as one of the greatest Haredi poskim in Israel, says that it is obvious to him and certain that not only is vaccination permitted, but it is an obligation to prevent danger to individuals and society. Right on the other edge of the Orthodox world, Rabbi Shlomo Aviner actually takes an almost identical view. And Rabbi Elyashiv, regarded as the Posek Acharon, really the last word in halacha in the previous generation, ruled that even those parents who were concerned about vaccination had an obligation to society to agree to immunization despite their concerns. And when asked the reason behind this ruling, he said that it's an issue of fairness and an obligation to share responsibility. He held that failure to immunize would amount to negligence. And he also said that the parents of vaccinated students have the right to insist that all other classmates be vaccinated, so not to subject their children to unnecessary risk. Rav Moshe Sternbuch, really the elder Haredi posek in Israel today, he strongly endorses a vaccination and considers it pikuach nefesh, a life-saving treatment that overrides almost all other prohibitions. Now, of course, we're aware of anti-vaxxers, including, you may know, a very prominent and influential American Rosh Yeshiva, who just less than 2 years ago, during a measles outbreak, referred to vaccinations as hoaxes. In fact, Rabbi Moshe Sternbuch's very, very strongly worded letter was really a way of refuting Rabbi Kamenetsky's opinion. For most of us, I think we'll agree the prospect right now of a vaccine is a godsend and it can't come soon enough. But what was the end of that story? Apparently, this guy, Henry Levy, then wrote to Chief Rabbi Adler for an explanation. Rabbi Adler has dignified the man, surprisingly, I think, with a response, and he said, Mr. J.H. Levy is not an authority on medical science. His opinions on the subject have therefore no value. And that is why this evening, rather than hearing from a rabbi, we're going to be hearing from a panel of experts. But before we hear from them, I've completed my introduction. We're going to show a presentation which has been prepared by Professor Benny Chain. Thank you.
Hello, I'm Benny Chain. I'm Professor of Immunology at UCL, and I wanted to take a few minutes of your time to explain what vaccines are and how they work. We are all very aware that as our children grow up, they face all sorts of physical dangers in their environment, which they learn by trial and error, partly to avoid or to deal with. But of course, we also teach them, we educate them to recognize danger and stay away from it. It took the human race much longer to realize that we are also faced with a different sort of danger, an invisible danger in the form of billions of microorganisms which live in our environment and on occasion can enter our body and cause disease. Remarkably, our body has a system, the immune system, which can learn to recognize these microorganisms, distinguish those that really pose a danger to health, and eliminate them or prevent disease. The system is very efficient, but it's not 100% efficient, and many children still die of infectious disease before their immune system has learned to work effectively. About 250 years ago, we learnt that just as we can train children to avoid physical danger, so we can train our bodies to recognize dangerous microorganisms and respond to them and prevent disease. This process is called vaccination. And today I'm going to explain to you how the immune system actually recognizes these invisible dangers in our environment and how we can improve on natural immunity by a process of vaccination. So I'd like to show you a little bit about how this system actually works. And I'm going to use for it a diagram which was drawn just over a century ago, around the time of the First World War, by a German Jewish scientist called Paul Ehrlich, working in Germany. And he wrote a book about what was then called the immune system. And I'm taking a picture from that book, which I'm going to show you, because the principles that he put forward then, long before he really understood how they worked, turned out to be extraordinarily prophetic. So if you look at the left-hand picture here, you'll see these round things. And these are how Ehrlich imagined our white blood cells to look at. We call them now lymphocytes, but they're basically cells in our body. And remember, these pictures, everything I'm talking about, it is at an immensely microscopic scale. So the real size of everything on this picture has been magnified by well over 1 million times in order for us to see it, and I can show you on the picture. It's completely invisible to the naked eye. So here are white blood cells, and he envisaged, he was particularly concerned at the time with diphtheria, which was causing a huge amount of disease at the time, and he pictures the diphtheria. Diphtheria was known to produce a poison which killed people, basically, if you got diphtheria. And he shows this as this black thing. It's kind of the evil toxin up here, and you can see it here. And he imagined that there are also other bacteria around. This might be tetanus, for example, trying to kill you. And each one, he imagined, had a slightly different shape. These objects we now know are called proteins. They're tiny, tiny objects, millions of times smaller than we can see. And they cause the damage by latching on to parts of our body and damaging them. What he put forward, and this was his great insight, was he believed that these white blood cells had on their surface other objects which were varied in shape, but of which there would be at least one which fitted, almost like a hand in a glove, an exact match for the shape of this particular object which was attacking the body. Could be a virus, it could be a bacteria, could be a poison, it could be anything. So there's a kind of a key and lock, if you prefer that analogy, between these two things. He called these objects, which were being produced by the cell, antibodies, anti-against, because they fitted against this object that was attacking them. And what he suggested was that the white blood cells would patrol the body when one of these dangerous objects was exposed, entered the body. For example, you scratch your finger on a nail and the bacteria enters into the blood. Then there would be an exact match between this object, the bacteria or the virus, and this antibody, this object on the white blood cell. And you can see how they match exactly. Of course, there would be this is a highly specific interaction. So this would work fine for this particular bacteria, wouldn't work so well for this one, which is pictures as being a different shape. And so there would be a different object for this. The trick is the following. When this object interacts with the white blood cell via this interaction shown here, the two interact like a hand in a glove or a key in a lock, then the cell, the white blood cell, produces millions of these identical objects and floods them into the blood. And it produces so many of them that they are able to mop up this dangerous molecule or this dangerous virus by basically sticking all over it and what he called neutralizing. In other words, the dangerous object, whether it be a bacteria or a poison or a virus, could not carry out its task. It could not cause any damage because it was completely covered, plastered with these antibodies, objects produced by the body, by the white blood cells, which block them. And so you would block infection. And what's more, these objects, he surmised, and indeed it turned out to be true, would hang around for weeks, months, or years in the blood, so that if you were exposed again to the same object, then the body would be pre-warned and immediately be able to block the invasion of this organism. Now, under normal circumstances, what would happen would be there'd be a kind of a race. The bacteria would try and grow and cause damage as quickly as possible. The body would try and fight against it. Usually the body wins, but as I said, in many cases, there wasn't enough time to make these objects. And so the bacteria wins and the body succumbs, or the human person who was infected would succumb. The trick of vaccination is very, very simple in essence. By exposing the body to something that looks very similar to the original object causing the damage. So in the case of, let's take another example. Let's take polio, which was a devastating childhood illness until maybe 50 years ago. That polio, you cannot expose, obviously, the body to polio itself. But the trick of vaccination, the insight was that if you took just one part of polio, perhaps its outside surface, so it couldn't cause any of the damage that the virus itself did, because it's really only a little part of it, and expose the body to it, it would be tricked into believing that it had been exposed to polio, and it would produce these antibodies, which would then block a future infection with the real polio itself. That is the principle of vaccination. And essentially, that's how vaccines work in every case that we know of today. And that is the principle on which the current attempts to build a vaccine against coronavirus. Again, we don't want to expose the body to coronavirus itself, because that causes damage before many people can protect themselves. Of course, in most people, the immune system works fine and they get better, but in some people it doesn't. But we expose the body to just one part of that coronavirus, and it's sufficient to trigger the body's memory. And note that this vaccine is highly specific. By producing these antibodies, you will be specifically protected against these sort of organisms shown here in black, but you will not be protected against this white one, for example, that has a different shape. So by getting a vaccine against diphtheria, you cannot be protected against polio. By getting a vaccine against polio, you won't be protected to diphtheria. Each one of these vaccines is entirely specific to the organism, or at least a family of organisms which caused it. That's really the principle of vaccination in just a very few words. I just want to, we've been sort of inundated with statistics and numbers, I think almost saturated with them. I just want to finish with one such number. Smallpox, perhaps some of you will still be old enough to remember the days before smallpox vaccination. But I wonder how many people are aware of the scale of the problem. In the years between 1900 and 1967, we estimate that 300 million people, most of them children, died of smallpox worldwide. 300 million people. And it's a horrible, horrible disease. You see here a picture of a child infected with smallpox. Now, we had a vaccine already, but it was not, it had not been rolled out on a worldwide scale. In the 1970s, the World Health Organization rolled out a world immunization protocol against smallpox. And as a result, by the late 80s, smallpox had been completely eradicated. In the last 20 years, there have been 0 cases of smallpox in the world, an astonishing feat. So just let me finish with the idea once more that I started at the very beginning. Just as we can educate our children to avoid the obvious dangers of growing up, so we can educate our bodies in exactly the same way to warn them of dangers at the microorganism level and to protect them from these infections. Thank you.
Well, thank you very much, Benny. That was an excellent introduction. So to get on to the next part of the evening, that was your explanation to vaccination and obviously under the general principles of it. We're very lucky tonight to have Benny with us. Benny's, of course, as you know, Professor of Computational Immunology at UCL. He's an expert not only in immunology, but also in how to integrate the mathematics and statistics that are required to actually formulate pathways and strategies to deal with not only infectious diseases, but also cancers and other inflammatory and infectious diseases. And we're also very lucky to have Madi Nursadek, who's professor, a close collaborator and colleague of Benny, who works very much in the field. He's a consultant in infectious diseases. His field is really in resistance to TB, and he's worked on HIV, and he's now switched as well to working on COVID. So it's really wonderful that we've got both of you joining us tonight. And what we'll do is we will have a discussion of some questions we should discuss together. Anybody who wants to ask questions can go on the chat, and they can, obviously, we will feed that back. This will go on for around 40 minutes or so. Well, it was due to finish at 9, but we were a little bit delayed, so perhaps a little bit past 9. And the other issue is that no advice from this evening should be taken practically. This is not here to really give you practical advice on what to do on vaccinations. So first of all, Maddie and Benny, how have these vaccines, and of course it's only the 9th of November when the first one was actually announced, and of course has transformed the whole excitement in the last few weeks. Do you want to just tell us a little bit about how these vaccines have been evaluated and how good you think this evaluation is at such an early stage? So maybe Maddie, you could start.
Thanks, Danny. Thanks for the introduction and for inviting me to join you tonight. So it has been a remarkable journey, I think, over the last 9 to 10 months to get to this place. I think the first vaccines in conception really started to be developed in late January, and to imagine that within such a short space of time we're already hearing about something about their efficacy and their safety is a really remarkable feat, and it illustrates the extent to which these have been prioritized by a worldwide community working on them. I think that what's really interesting about this particular effort is that there's been a huge amount of innovation about the manufacture and testing of the vaccines. So often vaccines would take quite a lot of time to manufacture in themselves, but then these vaccines that are emerging at the moment use new technologies that we're able to manufacture really very rapidly, which is obviously a key thing. And the second, I think, really interesting phenomenon is the degree of collaboration that has taken place across the world by many groups in order to be able to test them widely in many different sort of settings. And each of the 3 vaccines that we've already heard about have been tested in over 10 to 20,000 people in each case. And that's quite a significant scale to be able to make real statements about the safety and, to some extent, the efficacy, at least the short-term efficacy of these vaccines.
Benny, what's your take on these things?
I mean, I completely agree with Maddie that the speed of development has been incredible. It's been essentially, it's been a technological development rather than a sort of any requirement for genuine new science. It's more a question of how we apply the science that we already know. But one interesting thing perhaps worth mentioning is the variety of different types of vaccine. So the very first vaccine that we used, became well known in the West, was the smallpox vaccine. In that case, the vaccine it has to be something that's similar to the infection, but not exactly the same. And in that case, it was a virus that infected cows with many similarities to the human virus. So the body was tricked, but it causes no disease in the human. So the body was sort of tricked into responding it. But in many cases, you can just use a small part of the virus, and that's now become the standard for many of the vaccines that we use in children. In the case of coronavirus, there's over 100 different vaccines currently in trial, and every possible approach is being made. There's a Chinese vaccine, which is the whole virus, the whole coronavirus, which has been inactivated in some way and then used as a vaccine. There are many vaccines being tried, which are just parts of a virus, as I said. But the excitement over both the Oxford and the Pfizer vaccines are that they are completely novel ways of trying to deliver virus parts to the body. They use a sort of a code. The proteins in the body are in general coded for by DNA, as many people know, and RNA, which is a very similar, close cousin to DNA, which contains the code. And in this case, these are what are being used to deliver the vaccine rather than the actual protein itself. So it will be very exciting to see how these new approaches actually play out.
Thank you very much. I mean, there's been a lot of confusion, obviously, because we were all waiting for the Oxford and AstraZeneca, and as to what is 90%, 62%, then you take the average and it's 70%. I mean, I know you're not involved in these trials and they haven't all been published, but I think it's actually been very confusing to people as to hearing about the various doses. I mean, could you just clarify that for us maybe a bit, Maddie? What is all this 90, 70, 62, over 55? Could you just make some sense?
So in general, the vaccine studies aim to undertake early what they call interim analyses after there have been a certain number of cases of COVID amongst the study group. So most of these have decided that their first look at the data will be when they've had about 100 cases of COVID in their study group. And then for the first time, they unlock the code to see who received either the vaccine or the dummy vaccine, if you like, the placebo, in order to see whether there's a difference between those two groups. And I think probably the Pfizer vaccine is probably the easiest to understand, or apologies, the second one, the Moderna vaccine is easiest to understand, which broke the code at 100 people and found that of the 100 that developed COVID, 95 of them received the dummy drug, the dummy vaccine, and 5 of them received the true vaccine. And that's how they calculated that the vaccination was 95% effective. So it's really the difference between those two numbers that approximates or estimates the efficacy of the vaccination. Those numbers are different for each of the three vaccines that have announced their first interim results. One of the difficulties in understanding these is that obviously they're each in different settings, and the degree of follow-up that there has been for the vaccinated participants in each study is slightly different. So we really do need to wait a little bit longer to get a better picture of the overall efficacy, effectiveness of these vaccine strategies.
Anything to add to that, Benny?
No, I mean, I think the crucial thing is the timing, really. Normally vaccines, you would like a vaccine to last, if not months, but even years. I mean, typically pediatric vaccines last at least a decade, and you have sustained. While here, because of the enormous time pressure, the vaccines are being tested literally within weeks or days of the dose being given. So that's probably the single biggest limitation on interpreting the data. We just don't know how long, how much of it is immediate protection, which will wane quickly, and how much of it is long term. That's
great. Well, thank you very much. I mean, I think the vaccination is what's, of course, excited everybody and hopes that we can all return to our normal activities. But there's a number of very interesting questions. So I'm going to bring in some of the questions that we've got on the chat now. First one is actually moving away from vaccines, and from Robin here is there's a rather pretentiously termed Great Barrington Declaration was made a few weeks ago. And perhaps you want to explain, Maddie, what that is and whether you can comment on it in any way. So that was a declaration, obviously, in the town of Great Barrington in somewhere in Massachusetts, regarding attitudes towards lockdown that got a lot of publicity. What do you want to just explain what the Great Barrington Declaration is, Maddie, and whether you agree?
Yes, I guess so. I mean, this is obviously a hugely controversial area. So the idea here is principally that COVID can cause harm directly by infecting people and making them unwell, or it can cause harm indirectly by the effects of lockdown. And the sort of principal view that underlies the Great Barrington Declaration by its authors was that you could shield in some way the very vulnerable in society who are at risk of severe disease, whilst allowing the virus to run its course in the rest of the population, and thereby avoid some of the most damaging effects of the various lockdown strategies that different countries have rolled out across the world. The fundamental problem with that is, and the idea is that eventually enough people will be exposed to have developed some natural immunity to the virus, what people you'll have heard of as being described as herd immunity. And because there's enough so-called herd immunity, then in general the virus won't be able to transmit very effectively across any population. The problem with this approach is really twofold. The first thing is that there are really no examples of true herd immunity developing over a short time for any microbial organism. And the idea that this could happen in the course of the next, I don't know, few months or years or even decades is really an unprecedented idea. And most, I think, credible views don't think that's very likely. The second problem is that it's extremely difficult to fully shield all of the vulnerable in society if the virus is genuinely transmitting everywhere. The Great Barrington Declaration called this focused protection, but most people think that that's really an impossible task to achieve pragmatically, and therefore I think the consensus in the scientific community would be against that approach.
Benny, you want to add anything to that?
Well, as Daniel said, I'm interested in computational immunology, which basically means I'm interested in how you can use mathematics to model biological processes with equations. Physicists do this all the time. Biologists are not very good at it. And basically the whole of epidemiology, which is trying to guess what's going to happen in an epidemic like the current one, is based on a mathematical model, because we don't know, we can't know what's going to happen in the future. We have to predict it based on an equation. I completely agree with what Maddie said, that it's very unlikely that we can reach this so-called herd immunity. But it's worth, I think, noting that the models that are used to predict these epidemics are notoriously very, very difficult to constrain to be accurate enough to make useful predictions. In other words, they'll tell you, well, you can have anywhere between 10% of the population and 80% of the population, depending on how you run the model. That's from a political point of view, from a politician's point of view, not terribly useful, because how do you make a decision? And I think what both the scientists and the politicians are trying to do here is to balance a very inexact science with equally inexact economic forecasting of what the impact is. And I do think there are many things about this whole epidemic that we still don't understand. So it does make it very, very, very difficult. Different countries with different lockdown procedures have had, in some cases similar, in some cases completely different approaches. There's no very simple pattern. The only thing that is absolutely clear is that if you're completely ruthless and literally confine everybody to their room, as was done in China in Hunan province, there you can control these epidemics extremely efficiently in a very short time. But when you start to try and find a middle road where you're allowing some things, not allowing other things, it's really hard to know what's effective and what's not effective.
Thank you very much. So, and going on to Ruth B, which is another issue a lot of people have raised. She says, how can our government or WHO fight against anti-vaccination groups, of which President Trump has been part one? I must say, in defense of Trump, which I never thought I would have to do, Trump is not anti-vaccination. In actual fact, he set up the program called Warp Speed. And in fact, he's annoyed that he hasn't got the credit for the vaccination. He thinks it was deliberately announced after the election result. But leaving that minor point, what about the anti-vaccination groups, which are of increasing influence and harm everyone? How does one deal with this effectively, or can one deal with it effectively? Can we introduce legislation, do you think, that will make it mandatory to have vaccination for school children, or which we do actually for some vaccines? Maddie, what do you think about the best strategy to deal with anti-vaccination?
I mean, I think that generally mandating things is not in the sort of tradition of the British system or the British way, and instead educating and providing all the information people need to make a sensible choice is probably a much more effective strategy. It's also a long game, so I think that you can imagine mandating by legislation something, trying to fix the problem overnight. But I think that's unlikely to be successful, and not probably a route that people, at least here, would want to take. But instead, taking care to explain and candidly provide all the information available, expecting people to be intelligent enough to make the right choice for themselves. That certainly historically has been the approach that most countries have taken, and that's been mostly effective. There will, of course, always be people who simply refuse or deny the weight of evidence, and I think that is a reality of a liberal society.
Yeah, I think it's one of the biggest dangers of trying to rush a vaccine into use if it hasn't been absolutely fully tested. The possibility of a backlash against other vaccines would be infinitely more damaging than the impact, the potential impact on this particular epidemic, which will sort of probably self-limit anyway eventually. So that's absolutely crucial. I think if people try and sort of trumpet the virtues of their own vaccine, whether it be for personal or financial,
let me just ask you there, Benny. I mean, what are the potential most significant risks of these vaccines? And this is a source of concern. I mean, Rob has asked this question, and that's, what are the safety fears? What can happen? What can go wrong with a vaccine, apart from contamination and issues like that? What can long term go wrong with a vaccine?
Maddie, you're probably best. Why don't you have a go at that?
Yeah. So maybe we can talk about, I guess the first thing is, I guess you mean side effects or adverse effects.
Yes, long-term effects.
Yeah. Well, so if I divide them into common things, which are generally mild and transient. These are, I think all of us will have experienced, for example, a little bit of swelling or tenderness or pain at the site of a vaccination, or indeed over the subsequent few days, a mild fever, for example, after vaccination. So those are quite common. They're mild, they're transient, and they don't have any long-term sequelae or consequences. They are not of any concern, really, although they're a bit irritating at the time of vaccination. The second group, which is extremely rare, are genuine long-term consequences. And I think that there are two types. There's sort of completely unpredictable, to some extent, allergic reactions that some people experience in the way you might be allergic to nuts or I don't know, dairy products or eggs or something like that. And most people will be asked specifically about their history of allergies before they're given a vaccination to assess any potential risk of having an allergic reaction to a new vaccine. The second sort of longer term and more serious side effect that we worry about are maybe best to describe them as autoimmune diseases that may emerge as a result of, as Benny described, educating your immune response to react to a particular bug. It may be that it accidentally reacts to something else in your body. That, although theoretically is possible, actually in real terms is exquisitely rare. And none of the vaccines that we currently use in common vaccination programs really increase the risk of these autoimmune events beyond what happens in the sort of normal population.
Okay. Well, a question again. This vaccine safety, which clearly is a source of concern, and I mean, Guido said, would the panelists have the vaccine? So I'm going to answer for the two of you and say yes, because obviously we will. And as to which one we have, we don't have enough information yet, so we'll just take whatever is given to us. But leaving that point, which is I think reasonable, is basically the comment from Polina, which is why is it that in the Haredi community there's no virulent epidemics despite continuing communal activity in large multi-generational families? Now, before opening this up to you, what you think the situation is in the Haredi community, I'm not actually convinced that that is actually true, because my impression is that the mortality in Stamford Hill was actually quite significant, especially in the first wave, and it certainly has been in Israel. But the question about it is that given, 7,000 Suttoners crowding into a stadium last week, and this sort of business and flagrant violations, why in that community do we not see a larger mortality, or do you think we see the expected mortality? Benny, do you want to?
Well, I don't really have the facts to answer that question. I mean, my impression was that in Stamford Hill, actually there were quite a lot of deaths in the first wave. I mean, the numbers in the second wave are significantly smaller everywhere, so the deaths will be also.
The death rate in the first wave was actually 4 to 5 times higher in the Jewish community, certainly in the first wave.
Yeah.
I don't think since then, and so I think it has been. I don't know about the Israeli community. I mean, do you have any information on that, on ultra-Orthodox communities in this country, Maddie?
I'm sorry, I don't have that that sort of insights into that particular community. I can't comment sort of intelligently.
0.4% of the UK population is Jewish, but well over 1 to 1.2% of the deaths in the first wave of coronavirus were among Jews. So obviously, I'm not saying all of those were the ultra-Orthodox community, but we certainly were 2 to 3-fold overrepresented in that. So I think it's a good question as to what's going to happen in that community. And of course, they have got a higher percentage of younger people who are more resistant to this. But we'll have to sort of examine that in due course. What is the MHRA's role in approving this vaccine? John Bowers has asked this, and how do we approve? How are these vaccines going to get approved? How are they going to get to us? What is the process of regulatory approval that is going to make them get to us? Maddie.
Yeah, so the MHRA is the UK regulator for medicines, and it's independent of any drug company or any other investigator proposing a new drug or vaccination in this case, and will have access to all of the data completely uncensored to do with the vaccine studies. Importantly, it sets the rules about how a trial is conducted to ensure that all the relevant information is captured, and has oversight in the conduct of the trial, as well as part of the conditions of being able to consider approving a drug or a vaccine for use in humans. I think that they have a really difficult role, because we're trying to drive through vaccine studies and get an early impression of their efficacy and safety at the earliest possible opportunity, which means that we will probably have less long-term data on both efficacy and safety than is routinely the case when the MHRA usually sort of consider new drugs and vaccines. But of course, they're trying to balance this against the need in society and at the individual level to find a solution for this infection. And I think that they do have a really very difficult role in that case, in that sense. So I think the positive thing to say about this is that they have an exceptionally good track record at the way they assess and approve drugs for human use. And the vehicle by which they will assess this will probably be under what's called a emergency use access, which is to make the vaccine available as they continue to assess its efficacy and safety as the trials continue.
Okay, well, I've got pooled a number of very interesting. I'm going to pool a number of very interesting questions. There's a lot of interesting questions here, and I think one of them is, and I'll address this to Benny first of all. Given, let's look at it from our community. We have a large number of vulnerable people in the community, particularly in the older age groups. First of all, how will we prioritize vaccination? And the second point is actually a more narrow one. Would you basically say that people who aren't vaccinated should not come to our shul? I mean, what would your views be on something like that? That was asked from Sue Gessler, and then another issue and a third issue on this is what % of the population would we need to be vaccinated in order to actually limit the spread? This is from David Scott, to limit the spread of the virus. So sort of 3 points there. First of all, how will we prioritize? Secondly, should we restrict access to communal institutions for people who do not vaccinate? And thirdly, how many of us need to vaccinate? I think all three of these are difficult but very important issues. Benny.
Okay, so in terms of prioritizing, I mean, I think the general view at the moment seems to be that we should prioritize by age and by vulnerability. And so when the vaccine, because the limitation will be the number of doses of vaccine available and the ability to actually deliver the vaccines. And I think they'll start with the older generation. I mean, one problem.
How do you define older generation? I mean,
well, I think
are you a member of the older generation?
Probably 65 and up, maybe.
Okay.
I don't know. I mean, I think it'll depend. I mean, they'll move down as quickly as possible. It's just a question of how many doses they can get going. I mean, one of the problems is that in general, vaccines work less well in the elderly. So, it's a slightly paradoxical situation that you're trying, the people most at need of vaccination are the people who respond least well to the vaccine. But I think that's what people will do. And then, as there's more and more, so more of the population will be immunized. I mean, I think it sort of links to the third question, which is what percentage do we need to reach? And that's a bit of an unknown. So in the case of measles, it's an often quoted figure that you need to reach 80% vaccination, at least in the population, in order to reach what Maddie was talking about, herd immunity. In other words, in order for there to be so few unvaccinated people that the virus simply peters out. Every time there's an infection, it doesn't meet enough other people who are susceptible to maintain itself. But there is a big difference between measles and coronavirus. In a family where one person gets measles, it's common for the vast majority of the other members of the family to get measles if they haven't already had it. That's called the penetrance of a disease, and it's very high for measles, for example. In the case of coronavirus, for reasons we don't understand, that figure is much lower. I mean, many of you, I think, will probably have had the experience that somebody's had coronavirus in a family, and then several other members who are living in the same household do not develop the disease. I mean, we had it in my own family. Julia got quite ill, and everybody else didn't get ill at all, although we were living in very close proximity. So somehow the penetration, and there's a general, I mean, there've been several studies now, and it seems like only about 20% of the family, of a household does get infected, 20 or 25%. So it may be that we will be able to dampen the epidemic with a lower amount of people infected, and particularly if we can immunize effectively the people who are most vulnerable and therefore also more likely to spread the virus. That number may be significantly smaller, but I think we won't know until we do it. There's no way of predicting it. Okay. What was the third? Oh, in terms
of the third one, maybe we'll let Maddie, because you might get into trouble with your answer. So we'll let Maddie, who's an objective outsider, answer this question. What about people who refuse to be vaccinated? Obviously, if they medically can't be, that's one issue. But if they refuse to be, what do you think is the issue? And is there any precedent for saying that they shouldn't be allowed access to, and how far do you take that access? Obviously not just to a synagogue, but to any communal institutions. And of course, we'll be faced with schools and whether children should be vaccinated, which is something you might want to comment on anyway. Do you think that this is likely to be an issue that we will have to even make conditions of access?
So if I may just take a step back and just say, one question is whether or not the vaccine that we have protects against disease or they protect against infection. So at the moment, the efficacy that's been reported is about protection against symptomatic disease rather than carrying the virus. If the vaccines protect only against disease and not carrying the virus, then clearly the vaccines, I think, will be prioritized for the vulnerable who will get severe disease to attenuate, to mitigate that risk. Whereas if they're able to protect against infection, a key is going to be to use the vaccine to stop the transmission of the infection through the community. And I think that speaks to your question, Danny, about then, can we mandate it? There will never be a circumstance, I don't think, where it will be mandated for everybody, because there will be individuals for a variety of different reasons who may not simply be able to have the vaccine. And so the issue is, you know, how will society, I guess, imagine what will society imagine is acceptable by and large? The tradition in this country is not to mandate, as we've discussed before, use for people who simply don't want it for whatever reason they stipulate. And I think the real trick here is to make the case overwhelmingly why it's effective, so that people will make the right choice.
Okay, well, I think we'll all agree that Piers Corbyn is not coming to our shul in the near future. But actually, in terms of the biology of the vaccine, the biology of the disease, there's two very interesting questions here. And one is from Rivka, which is about the potential for this virus to mutate. And obviously, there's been stories about these mink and other things, and perhaps that's something you could comment on. And the other one is from Rob Ginsburg, and you know, and it's coming on from something Benny has said before, which is really this incredible heterogeneity of response of clinical of the clinical course of people, ranging from nothing to in ventilated patients, and of course the long COVID issue. So two issues there. One is the issue of mutation. What do we know? Secondly, the issue about what is it that makes there so many different clinical outcomes and so many different types of COVID that people are having. Any insights that you've got onto that? Maybe you start, Maddie, with that.
So if we talk about mutations, I guess, so one of the remarkable things technologically that we've been able to achieve in the last year is sequencing tens of thousands of virus strains and making them publicly available so that people can study the mutation rate and the effects of the mutations. And thus far, although there has been quite a lot of new mutants or new strains of virus being described, there isn't any evidence that the mutations are associated with a change in the ability of the virus to infect or cause disease. That's where we are at the moment. The really interesting question is what will happen when vaccination is introduced? Because under the pressure of vaccination, the evolutionary pressure of vaccination, there is a possibility that the virus strains that escape the vaccine are the ones that can mutate or change their shape so that the vaccine is no longer effective. And in that circumstance, I think there will be a sort of ongoing surveillance of mutant strains so that we can adapt our vaccines accordingly, as, for example, we do to some extent with the annual influenza vaccination. The question of why some people become ill and others remain well is a huge enigma still. And I think that it will still probably be some years before we work that out for any significant number of people. Some of this might be stochastic. You know, for something to go wrong, for you to become unwell, maybe all the holes in Swiss cheese have to line up in a particular way, and just by the throw of the dice, some people become unwell. But in fact, because we can predict who is at risk of severe disease, it's much more likely to be some biological reasons for this, for example, related to age and other diseases that people might have. But the mechanisms, we still don't really have a good idea of.
And minks and mink, any comments on minks and other animals? Or
I might leave that to Benny.
I don't have much to say about minks, but I'd like to say, I mean, I think we honestly don't really know, not just why some people get ill or what some people don't get ill. We don't really understand why people get ill in response to coronavirus. So like very many infections, the illness is probably associated with our own exaggerated response or inefficient response to the infection rather than the virus itself. That's true for very, very many infectious diseases. It's certainly true, for example, for tuberculosis, which is what Maddie studies. It's true for flu, probably, and many other diseases. In the case of coronavirus, we think that's probably true. One of the reasons is that if you measure how much virus is in people, the amount of virus sort of peaks very early at about 6 or 7 days after you get infected. There's a kind of 3-day lag when nothing much happens. Then you start feeling ill. And if you measure virus, that's when you start building up virus in your respiratory tract, and it peaks. And then it goes right down very quickly. But the really severe symptoms of disease often don't develop till 2 or 3 weeks post-infection. So it's not the virus itself that is causing the disease, but the response of our bodies to it. But exactly how that works out is something that I think is probably scientifically the most important and interesting question in COVID biology, and it's still definitely not understood.
Thank you very much. We're coming up to the end now, and we've got last questions, but I think very important ones from Veronica and Kennard and Sarah Woolwich. So Sarah's saying that just with the flu jab, and you mentioned older people not being able to mount such a good response, does just giving more a more powerful dose, does that facilitate protection? And the second question was really from Veronica about whether children will need to be vaccinated. And I think the other point about it is you know, will there be a situation in which we have combination vaccines that you might actually even end up with more than one vaccine? So, Benny, what's your views on that?
What was the first one?
First one was whether a bigger dose of vaccine.
Oh yeah. Well, I think, I mean, some of you will have seen in the papers the rather paradoxical suggestion that the AstraZeneca vaccine actually worked better when the dose given was smaller. I think in practice, it won't really be possible to I mean, the timing will be such that whatever works will be given. I think just giving more of it is unlikely to be more effective, and people are trying to work out the most effective dose in any case. So I doubt whether there'll be any difference, at least in the first wave of vaccination, between the vaccine given to older people and to younger people.
And what about mixing the vaccines? You know, if you have two different vaccines, then presumably you've got a better chance of...
I think the only case where that's a likely thing to happen is if there's extensive mutation, as Maddie has suggested, in response to the vaccine. So in the case of some bacterial vaccines, for example, what we do is we mix, the vaccine is a mixture of strains so that we cover as many strains as possible. And that may be the case. But I think the logistics of delivering a vaccine, a new vaccine, are even for a single vaccine, are so big that I think the idea of mixing them is not going to be, at least in the foreseeable future, likely. So it's just too complicated. It makes the safety evaluation much more difficult. The whole thing becomes just a nightmare to actually carry out. So I doubt whether that will be done in the near future. In terms of children being vaccinated, I think that'll be, I mean, it seems pretty clear that for younger children, the severity of disease in the vast majority of cases is very slight, and also it doesn't seem that the transmission from children is a very high, is very effective. So I doubt whether there will be at all high priority.
Thank you very much. Maddie, anything to add to those?
Just to add a sort of positive note about the effectiveness of the existing vaccines in the elderly. We don't actually have line of sight of the actual data, but in their press releases, both the Pfizer and Moderna vaccines made the point that their study populations included elderly patients over the age of 75 and a wide diversity of ethnic groups. And they see no significant differences in the efficacy in these different subgroups of their study. So if that's true, that's really promising to suggest that actually this is a vaccine that might work in the elderly as well.
Thank you very much. And I think just I'll ask both of you to just sort of wind up with a couple of sentences. Before doing so, I mean, I think that we shouldn't allow all of this talk about anti-vaccination, I think, to take away from the incredible triumph of actually a disease process in 9 months moving towards a potentially effective vaccine, which is an absolute triumph of immunology and infection and vaccinologists. It's really staggering. And a number of people have asked whether this will be applicable to other viruses, and I'm sure it will be. And I'm sure, of course, concerted international effort in the future when the next time someone eats some strange animal that's creeping out of the jungle somewhere, and we pass on this virus, hopefully we will actually be able to mount very effective international effort to stop it. But I would like to thank very much Maddie and Benny for the most excellent presentations and discussion. But before we sort of sign off, I wonder if either of you have any particular other points that we haven't covered that you'd like to make. So Benny.
Well, no, I just want to sort of end really by stressing again that, as you said, I mean, not just this vaccine development, but the progress of vaccination over the last century, and particularly rapidly, really, over the last few decades, has been quite astounding. And but there are still massive challenges which I think can be and will be solved. We don't have a good vaccine for HIV, for example, which is still killing millions of people. TB is killing as many people as coronavirus, and yet we don't have an effective vaccine against that. And increasingly, there are many who believe that it'll be possible to have vaccines against some forms of cancer. You can already prevent, for example, cervical cancer by vaccinating against the virus that causes that cancer, and so on. So I think it's been a tremendous success story with really, I find it extraordinary, really, that people are skeptical of what seems to be such a remarkable advance in improving human health. And I think the vaccine immunologists have a lot more work to do, which is great news for me and Maddie.
Maddie, anything that you want to sort of sign off with that we haven't covered?
Yeah, I mean, many people very frequently say 2020 has been a terrible year, and for obvious reasons. But I think one of the striking things is how it's illustrated that this sort of necessity and the urgency is illustrated how the scientific community can come together collaboratively to achieve really what is an incredible feat over a very short period of time. And I think it gives us a blueprint for how we can make progress much more rapidly in the future with other challenges as well. So I think we will have learned a really big lesson from our experience this year.
Well, thank you very much. And thanks, of course, as always, to Joel, who sets this up and has technologies. And we all can see the massive distractions that go on in the background, Joel, while this goes on. And so we're very grateful to you for running this. And again, Benny and Maddie, thank you very much. And Rabbi Belowski, we hope to see you back in the shul sometime. And
Daniel, I'm not going to let you get away without thanking you as well, because I think you stewarded an excellent discussion, and it might be time for me to hang my hat up and hand over to you for leading discussions. Just a very final thought. This was in 8 months of running Zoom events nearly. This was the very first time that we exceeded the 100-person capacity limit on our account, which means that I know there were a few people who didn't manage to get in. Just to reassure everyone watching and those who didn't get in, that it has been recorded and will be available to watch in a day or so's time. But also to observe that I think exceeding that capacity is a sign not just of the timeliness of this program and the demand for information on this topic that there is inevitably, but also just the accessibility with which you've presented some really complex ideas and information this evening. And I think everyone in our community knew that Benny and Daniel could be relied upon to do that, and they've certainly learned the same of Maddie over the past hour. So thank you very much to the three of you for taking the time for presenting, and hopefully we can repeat again in the future.
Thanks, Joe.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.